a little bit of Zoom education for you not to miss any part of the screen. Go on view options and click on side-by-side mode. And if you feel like that your screen is freeze or something like that, maybe it's useful that you close every other program or app that is open on your computer. This may help you to get a better connection. So we want you to talk to us during this meeting. You can type anything that you want on the chat box. Where are you from and all of that. And don't forget to click on all attendees and panelists so everybody is going to be able to see what you're typing. And if you have specific questions, I'm sure you're going to have, please don't type on the chat box. Type on the Q&A box, and then all the panelists, all the speakers are going to try their best to answer all of your questions. And we are going to have two question and answer session, two discussion sessions, one in the middle of the webinar and one in the end. We hope all of you can participate. So our next activities, we want to see you on Friday on our morphology series of Dr. Anderson. So we are going to talk about discordant AV connections. It's going to be awesome. And then next Thursday, we are preparing something very, very special to all of you, including a keynote lecture of Dr. Jacob. We are very, very proud and very happy to have this surgical meeting next Thursday. Please join us. Now, Sasha.
Yes, thank you, Grace, and welcome all the people to this, again, special webinar that we are hosting together with the Pediatric Cardiac Intensive Care Society. That it's amazing. And it's my real pleasure to introduce Edgardo Banille, who participates to the Congenital Art Campus in Ortigia. So he participated to the one of the founder meeting of this platform. So Edgardo is a professor of the Catholic University in Pediatric Faculty, and he will talk about non-invasive monitoring of microcirculation in patients with cardiopulmonary bypass. Thank you, Edgardo.
Thank you, Sasha.
If you can share your screen.
¿Cómo cambio?
And we are very excited about this meeting because I'm sure we all are going to learn this state-of-art monitorization. This is going to be nice. Great, let's go, Dr. Edgardo.
Good morning, I'm Edgardo Banille from Córdoba, Argentina. Thanks to the Congenital Heart Academy for granting me the opportunity to take part of their activities. Thanks to my friends Joan, Rafa, Korbin, and Pablo for their qualified contribution to the webinar. Thank Dr. SASHA Gatti for the invitation to share this exciting topic, non-invasive monitoring of microcirculation in patients with cardiopulmonary bypass. Excuse me for my English, which is not that fluent. I will do my best to understand you. No pasa. Objectives: to know the normal physiology of microcirculation, to identify the changes caused by SIRS in microcirculation, and to diagnose the different types of hemodynamics instability. Until recently, the microcirculation was considered a black box between arterioles and venules. So let's open the black box. The anatomy is illustrated in this image. In addition to the endothelium, the capillaries have a thin muscle layer and a sphincter that receive stimuli and regulate flow. Microcirculation is the circulation within microvessels, which are found between terminal arterioles and postcapillary venules. It is a complex network that integrates information through a signaling system. Microcirculation has three main functions. First, it ensures the adequate oxygen delivery to tissue. It also regulates capillary blood flow and peripheral vascular resistance. And lastly, it has selective impermeability, secretory, immune, and anticoagulant functions. We can see the transport of oxygen coupled to hemoglobin from the lung to the mitochondria. Oxygen exchange takes place in a capillary where the tissue adapts to the different needs. For example, in a shock state, oxygen delivery takes place not only in a capillary, but also within arteries and veins through diffusion and convection mechanisms. When it comes to oxygen diffusion, the capillary density and the distance between erythrocytes and cells is as important as the flow. Endothelium, angel or demon. We can see it is an angel in normal condition. It is considered an integrated and active organ with more than 1 trillion cells and an extent of 4,000 to 7,000 square meters. This image shows different types of endothelium. Vascular tone result from the balance between the activation of vasoconstrictor and vasodilation receptor, where the endothelial nitric oxide is the main element. During endothelial dysfunction, vasoconstrictor or vasodilation will be exaggerated. If extreme, the result is a cold or warm shock. When there is an additional oxygen demand, the erythrocytes suffer a transformation to increase oxygen exchanges. 1. The erythrocytes increase in size. 2. The spherical shape changes to a sort of parachute shape to have a larger exchanges surface. 3. They move to the central region of the capillary to increase their speed. Finally, the stimuli travel to the endothelial purinergic receptor through the ATP receptor, producing vasodilation. Pay close attention, as it is at this level that Dr. Jill Warnowski teaches us how to balance univentricular circulation with a simple respiratory maneuver. He uses hypoventilation to generate hypercapnia. For example, in the preoperative Norwood procedure, permissive hypercapnia increases the cerebral flow, limits pulmonary flow, and improves tissue oxygenation. The same for the postoperative Glenn procedure. Activated endothelium. Third, definition: abnormal, uncontrolled response to the notion stressor, such as major surgeries, sepsis, burn, polytrauma, cardiovascular bypass. First paradigm is the COVID infection. The final effect is endothelial dysfunction, which is procoagulant, pro-adhesive, and vasoconstrictor. Where are these SIRS take place? In the activated endothelium, which become a demon. Who are the protagonists? Circulating immune cells, tissue immune cells or macrophage, non-immune cells. Other factors are cytokines, adhesive molecules, selectin, integrin, and glycocalyx, which is a semi-permeable membrane. Who are the star players of bouncing? Endothelial nitric oxide synthesis is triggered by the pulsatility of the blood flow. For example, in Fontan-Krauser surgery, the loss of pulsatility can cause pulmonary hypertension. On the other hand, the venous endothelium of coronary bypass acquire arterial characteristics when receiving pulsatility flows. Small vessels, big problem. SIRS produces alteration in microcirculation in all its components. On the other hand, other factors cause vasoparalysis or vasoplasia, vasodilator profile. The most important are nitric oxide overexpression, vasopressin depletion, and inflammatory mediator release, cytokine storage. On the left, we can see the inactive endothelium. When there is an inflammatory stimulus, the endothelium is activated and leukocytes are caught and introduced into the tissue, stimulating macrophages and that release inflammatory mediator like cytokine and interleukin. The next video is an analogy of what happens during SIRS. SIRS truly is a biological and cellular war. Non-invasive monitoring of microcirculation. It is possible, yes. How? Indirectly, through its functions, via tissue oxygenation and via capillary perfusion, which are evaluated through biomonitoring, NIRS, and cerebral and abdominal Doppler vascular. The oxygenation markers are venous oxygen saturation and the oxygen extraction index. The perfusion markers are lactate level, PCO2 gap, and the respiratory ratio. This chart shows the factors that alter DO2 and VO2. To ensure that the decrease of central venous oxygen saturation is due to low cardiac output, we must discard all these confusing factors. Continuous monitoring is ideal. The analysis of central venous saturation and oxygen extraction index determines the adequacy of tissue oxygenation. Normal value 25%, high 30 to 40%, in-minute shock 40 to 50%, over 50% shock state. We have to act at high level to avoid major complications. In this image, we can appreciate it that during the distributed shock, there is a greater oxygen extraction and the early critical DO2 point. Hyperlactatemia can be type B secondary to hypoperfusion and cellular hypoxia, and type B not related to hypoxia. PCO2 gap increases during anaerobic condition and the low flow condition. Respiratory ratio is CO2 production over oxygen consumption. It is a marker used in septic patients in recent years. This is a better marker of global anaerobic metabolism and perfusion than lactate level because the kinetic of PCO2 is faster than that of lactate. During anaerobic metabolism, hydronic ion bound to bicarbonate generated carbonic acid. This dissociated into CO2 and water increases the respiratory ratio. If we imagine microcirculation, we can find different scenarios. The upper part of the image shows normal circulation. Below, there is an example of the hypovolemic shock. The capillary flow slowed down due to peripheral vasoconstriction, showing a drop in venous oxygen saturation. In the third line, we can see a septic shock in which most of the capillary do not exchange gases, while other capillaries do not have flow at all, vasodilation profile. The line in the bottom shows a mismatch pattern of a septic shock and the hypovolemic shock. We published this table with hemodynamic profile with multifactorial assessment regarding septic patients. To sum up, vasodilation and vasoconstrictor profile, we can see the diastolic blood pressure and pulse pressure can be the first thing to identify the profile. Here is a case report of a 14-year-old patient with pneumonia and sepsis. He didn't respond to vasoactive drug. The hemodynamic profile is a refractory vasoplasic shock, methylene blue star. After the methylene blue infusion, the patient responded and his heart rate gradually decreased. Diastolic blood pressure and mean blood pressure were normalized just an hour after the infusion. It was also possible to decrease vasoactive drug. Initially, the central venous saturation was elevated, 86%, and the oxygen extraction index was very low, 7.7%, in accordance with the vasodilation profile. On the other hand, PCO2 gap indicates tissue acidosis. All values went back to normal after 12 hours. And these are using formulas. Conclusion. The best monitoring method is the human factor. A good nurse and clinical judgment will allow us to interpret the trends of the monitoring variables. Trends in the PCO2 gap and lactate values have adverse effect prediction. The respiratory ratio reflects anaerobic metabolism earlier than lactate. The persistence of the respiratory ratio over 1 suggests persistence of hypoxia, mitochondrial dysfunction, and insufficient resuscitation. Hidden shock. Say no. Non-invasive monitoring is very useful and economic, but can be inexact. If available, the ideal strategy is invasive monitoring with pulse control system. Microcirculation is ideally monitoring with video microscopy. This is the recommended bibliography. These are our book on intensive care, and this is a photograph of our hospital. Thank you very much.
Gil. Thank you very much, Edgardo. Sorry, we have misunderstanding with Gil. Thank you very much, and I'm sure there is some question already in the question and answer box, so I hope you will help us to answer. Go to the care, and now we move to University Hospital in Madrid, Gregorio Marañón General Hospital. It is Dr. Rafael Gonzales Cortez, who is an attending physician, and his party is a member of the Microcirculation Study Group in the European Society of Pediatric and Neonatal Intensive Care, ESPNIC. So it's my pleasure to introduce you, and the topics is microcirculation monitoring by video microscopy in post-cardiovascular surgery. Thank you very much.
Okay. First of all, thank you very much for the invitation to participate in this webinar. I'm really excited to be sharing this time with all of you. You have my email and my social media address there. You can write me if you want to ask any question. discuss these points we see in this slide. What is the microcirculation? Why should we aim to evaluate the microcirculation during the post-cardiovascular surgery period? How can we evaluate the microcirculation using videomicroscopy? And how is the microcirculation modified with cardiac surgery in children? Microcirculation looks like this. It adapts to every single organ in the anatomy. And if we look closer, we can see how microcirculatory vessels are covered by this hairy layer, which is the glycocalyx. Edgardo has already talked about functions of the microcirculation. We have to remember that it's involved in very different functions. Besides transportation of substances like O2 or nutrients and removing waste from the tissues, it's involved also in vascular tone regulation, interaction with blood cells, coagulation and fibrinolysis, and it also regulates vascular permeability. We have to remember that every organ function relies on the capability of the cardiovascular and respiratory system to provide oxygen and nutrient to the organs, but also on the capability of the microcirculation to deliver oxygen and nutrients to the cells in the tissues. We have to remember that the amount of oxygen that is removed by the tissues from the blood, which is called oxygen consumption, it's depends on oxygen delivery, which mainly it's regulated by the cardiovascular and respiratory system, but also on the oxygen extraction, which it's mainly regulated by the microcirculation. In this graph, we can see how oxygen consumption and oxygen delivery are related, and the extraction is dependent of this line. We can increase oxygen delivery, but from a certain point, we increase the delivery of oxygen to the tissues, we can get no more consumption from the tissues. If we get over this line, in the upper part of this line, we get in a condition in which cellular requirements are not fulfilled by the delivery of oxygen. In disease and in the physiological conditions, this line can be moved upwards or downwards. Usually, during the post-operative period, we mainly focus in modifying the oxygen delivery, which depend on cardiac output and on the arterial content of oxygens. And there are some conditions like arrhythmias, decreased cardiac function, hypovolemia, anemia, or hypoxemia that can decrease oxygen delivery, and that we might. But we usually forget about the lower part of the slide, the oxygen extraction. The microcirculation, it's really important to provide oxygen to the tissues. We can have decreased vessel density or decreased blood flow, or we can have an microcirculation with increased heterogeneity, or we can have edema in the tissues, and those can lead to a impairment on the microcirculatory compartment, decreasing oxygen transport. Why should we aim to evaluate microcirculation in the post-cardiovascular surgery? There are very different factors involved in the cardiac surgery, like fluids, the cardiopulmonary, cardiocirculatory bypass, the administration of blood products or different drugs, changes in temperature. All this can lead to microcirculatory disturbances, and this can lead to organ failure, worsening the outcome of our patients. I would like now to introduce this concept of coherence in the microcirculation. Coherence means that systemic hemodynamics and microcirculations are coupled. If we get to an improvement in cardiac output and blood pressure, we also get an improvement on cellular oxygenation and tissue perfusion. But the opposite, the loss of this coherence, can be a really bad sign. This means that system hemodynamic microcirculation is still impaired, and this worsens the prognosis of our patients, because the treatments we are giving them might originate adverse conditions on them. As Edgardo has explained, there are several methods to evaluate the microcirculation. We have physical examination, we have the biochemical methods, we have regional perfusion measures like Pablo will talk later about NIRS. We can perform also vasoreactivity test, but what I'm going to talk about is the use of videomicroscopy, a technique that can give us direct visualization of the microcirculatory compartment. Is based on this in the early 90s. The patent we see the picture on the left was developed to try to provide a count of blood cells non-invasively in the capillaries of the conjunctival area of the eye. From this technique, different development of different technologies have led to the possibility of visualizate capillaries in vivo. Orthogonal polarization spectral imaging, side stream dark field imaging, and the newest incidental dark field imaging consist on the illumination of a tissue with a wavelength that is reflected by the cells in the tissue that are carrying hemoglobin, and give us images like the ones we can see in the picture now. We can see all these dark spots moving around the image, which are red blood cells. There are several devices that can give us this kind of images, and we can record them in a computer and then analyze them. These are some other images. We can see how they look different. The ones in the left might look a bit healthier with more density of capillaries and red blood cells moving faster than the ones in the right. There are two papers that gather all the information to evaluate microcirculation using videomicroscopy. The last one was ruled out on 2017, and well, it is an actualization of the previous one, and there they describe the different parameters that you have to evaluate when you are looking at microcirculation images. Using similar example as the one that Edgardo has used before, we have to remember that oxygen content in the blood vessels decrease along we move through them, and also in the tissues the oxygen content decreases as we move away from the center of the tissue, which is where there is a capillary or the blood vessel. As we move away from this vessel, the amount of oxygen in the tissue decreases. Microcirculation is defined functions: the convective flow, which is the speed of the blood moving through the vessels, and might be determined calculating the flow velocity or the proportion of perfused vessels. Also the diffusive capacity, which is determined by the vessel density in the tissue that we are evaluating, like we see in the picture in the left. And also the heterogeneity. We can have areas in an organ with very different perfusion, like we see in these crops. There are areas in which we get a good amount of water and they grow green, and there are some others in where it's dry because they are not getting any water. Moving on with the same example as before, we can talk about an impairment on convective capacity. When the flow is decreased, we see how the amount of oxygen that we can provide to the tissues is decreased if we decrease the flow in each vessel. We have 5 different vessels with normal flow, and if we decrease the flow, we see that the amount of oxygen that we can provide to the tissues is diminished. When we talk about the impairment in diffusive capacity, we say that we have less vessels than in the normal condition. In the right side of the picture, we see how moving on from having 5 different vessels with normal flow to having 3 vessels with normal flow would result on a decrease on the amount of oxygen that we can provide to the tissues. This paper by Otge Erdem from the Netherlands describes how coherence might be altered in critically ill patients. They describe 4 types of microcirculatory alterations that result on the loss of hemodynamic coherence. The presence of heterogeneity, the presence of hemodilution, the presence of constriction due to pressure at the end of the capillary compartment on the venous side might result on an alteration on the microcirculation, and also the existence of edema. If we get fluid leak into the tissues, the distance from the cells to the vessel might increase, and then the cells might result on hypoxemic cells. Moving on how is microcirculation modified with cardiac surgery. There are quite a lot of papers talking about how it is modified during cardiac surgery in adults, but this is mainly involving patients with valve replacement or bypass, coronary bypass. And there are 2 papers in children which I would like to discuss deeply. There are also some other papers talking about microcirculatory evaluation using videomicroscopy in patients on extracorporeal life support. In the first of the papers that I have mentioned from the group of Claudia Nussbaum in Germany, they show how the thickness of the glycocalyx, this hairy layer, was decreased immediately after surgery in the T1 time point. In the later postoperative period, the glycocalyx thickness recovered. They also show how microcirculatory flow and vessel density were decreased immediately after surgery, and they recover 24 hours later. We can see in these two graphs how in the first measurement after the surgery, microcirculatory flow index and perfused vessel density were decreased, and these disturbances were more severe in the most complex surgeries. We can see here how those patients with aortic plant or deep hypothermia beside the cardiopulmonary bypass had more severe disturbances. In the second study from the people from the group of Sabino Scoletta, they didn't find significant changes in the microcirculatory variables from the baseline time point till the 12 hours after surgery, but microcirculation was different on the patient with cyanotic congenital heart disease. But we have to go back to a question that is very important. Can we really perform microcirculatory evaluation in every patient we are treating? This study in adults, it's a multi-center study. They could only evaluate 70% of patients in ICU, and in some of them it was due to the condition of the patients. In our study, we tried to evaluate if it was possible to evaluate in every single patient admitted to our PICU the microcirculation using videomicroscopy, and we could only evaluate it in 20% of the patients because most patients were not collaborative or had respiratory difficulty. But the patients in where we could perform the measurement were those who were intubated on admission or were on ECMO, and they were sickest. They had longer time of mechanical ventilation, longer time of stay in the ICU, and longer time of vasoactive drugs use. We have also described how vessel density is higher in cyanotic patients. This was a phenomena that we all suspected, but it haven't been described before using videomicroscopy. We saw how comparing patients with congenital heart disease, how those with cyanotic conditions tend to have higher vessel density, probably as an adaptation to the chronic hypoxemia. In this study that we have not yet published, is under consideration. We evaluate in 24 different patients with very heterogeneous surgeries. The microcirculation previously to the surgery, during the cardiopulmonary bypass, and after the surgery before admission to the PICU. And what diffusive capacity and convective capacity were decreased. We can see in these images how in the T1 point, which is the cardiopulmonary bypass, the vessel density was decreased, and also the flow capacity, the convective flow capacity was decreased. Then after surgery, both the vessel density and the flow recovered to the previous conditions, but there were some patients in where they did not recover to previous condition. They kept their situation altered. We saw also that heterogeneity tended to increase during the surgery, during the cardiopulmonary bypass, and return to previous values after the surgery. But again, we see how some patients kept an altered microcirculatory compartment after the surgery. More visually, we can see the behavior of our patients, like we see in the images in the upper left corner in the basal situation. Then patients get to one state where flow is clearly decreased, and also the number of vessels we see is clearly decreased. And then most patients recover microcirculatory compartment in the postoperatory time. But we must remember that some patients don't get to a normalization of the microcirculation. We use the microvascular flow index to determine how which patient have altered flow in the microcirculation, and we saw that during the intraoperative period, most patients have an altered microcirculatory flow, and we saw that this was more frequent among cyanotic patients, in which this appear in almost all of them, compared to non-cyanotic patients. So we can say that cyanotic patients might be at higher risk of microcirculatory dysfunction. We also try to correlate the microcirculatory variables with prognostic variables, and we saw that the value of microvascular flow index after the surgery was inversely related to the length of stay and the length of mechanical ventilation use. Finally, I would like to give you an example of two has a non-cyanotic cardiopathy, and the second one has a cyanotic cardiopathy. Both of them came out of the surgery room requiring ECMO due to ventricular dysfunction with similar conditions. We can see how blood gases look similar in both. We get serum lactate with normal range. Venous saturation was lower and oxygen extraction was higher in the patient with cyanotic cardiopathy. And if we take a look at microcirculation, despite both were well assisted on ECMO, we can see how the patient B on the right had a decreased flow index. There were some vessels with cells not circulating through them, and the proportion of perfused vessels was also higher in this patient. To finalize my presentation, I would like to get to some key points and pitfalls on the microcirculatory evaluation using videomicroscopy. We have to remember that there are several techniques available. They have prognostic capability. They allow us to evaluate different microcirculatory characteristics. We can perform direct evaluation and perform repeated evaluations, which might be useful to see the response to different treatments. But we have several points on that we have to take into account. Microcirculatory evaluation is time consuming. Most software existing now is yet relying on the operator and takes some time to evaluate each single video. There is lack of specific therapeutic measures directed to correct microcirculatory disturbances, and there is also a lack of defined target values for the microcirculatory parameters. As conclusions, we have to remember that microcirculation is defined by three different aspects: the diffusive capacity, the convective capacity, and the heterogeneity. Microcirculation is modified in children undergoing cardiac surgery and tends to return to the previous situation after surgery, but it does not return in every patient. Cyanotic patients might be at higher risk, and it might be useful also to predict evolution. We have to remember that microcirculation compartment and systemic hemodynamics are not always coupled. We have to keep in mind the phenomena of coherence and remember that a patient in which systemic hemodynamics look well might not have a normal microcirculatory compartment. And finally, we have to remember that we need further research on microcirculatory evaluation in pediatric patients. And this was all what I have to tell you about this.
Amazing, amazing presentation, both of you. It was very nice. We've learned a lot, and we hope we can use this on clinical practice soon. So now we are going to start our pool, our break. So for everybody who is watching us, we are going to have some question and answers now, and we want to know your opinion. We're going to make some questions for you, and then after that we have 3 more amazing talks. So stay with us. Sasha and Gil. Okay, we want to know where are you from? Please vote. So let's see. Most of you are from Latin America. It's nice for you to know that all of our speakers are Spanish speaker today. This is very nice. And we have a big compound of Asia as well and Middle East. Thank you, all of you, to stay with us. We hope all of you are enjoying. Okay, let's go to the next one. Okay, how do you define your practice? Anyone from Aligned Health, please click on NIRS. We don't have Aligned Health here. I don't know why, but the next one we are going to have it. Sorry for that.
Italian style. This is my fault.
You are never wrong, boss.
Okay, here we are.
Well,
Gil must be happy. Eh? Gil, you must be happy. Look.
No, there's not enough surgeons, Sasha. We need more surgeons to participate.
Not for this topic, please.
Well, I won't say that the microcirculation and the surgeons don't mix, but I'll hold off on that.
So now we move through the first question from Edgardo. Edgardo, if you want, you can comment, answer your question.
Which the following hemodynamic profile suggests as vasoplegic shock? Arterial oxygen saturation 94, PCO2 40, lactate 1.5, systolic blood pressure 90, and diastolic blood pressure 65. Oxygen, venous oxygen saturation 75, and PCO2 45, and lactate 1.5. The next, the same saturation arterial and PCO2 and lactate, and the difference is systolic blood pressure 90 and diastolic blood pressure 35. Oxygen, venous oxygen saturation 80 and PCO2 50, lactate 3.5. And lastly is, pardon.
Okay.
Edgardo, are you happy with this answer?
We can see Sasha.
Ah, sorry. I'm very egoísta.
Speak in Spanish. Cuando uno tiene una diferencial, una presión diferencial amplia, puede ser la primera pista diagnóstica de un shock vasopléjico, porque eso expresa de que hay poca extracción, hay vasodilatación en la microcirculación y poca extracción de oxígeno, porque tiene un flujo rápido a nivel microcapilar. Cuando es un shock frío, las resistencias periféricas están elevadas por vasoconstricción y da diastolic blood pressure elevadas.
So are you happy or not with the answer? Because it's a 50-50.
Correcta es la option 2.
Thank you.
Perhaps someone could translate the answer. I know it was a long one, but it would be helpful to those non-Spanish speaking. I followed a couple of things. I heard diastolic blood pressure, Edgardo. So, but your English was
Gil, if I may.
Thanks, Juan. Thanks, Joan.
If I may intervene, I will not turn my video on because I have an unstable connection for some reason. But what Edgardo was saying essentially is to focus on the diastolic blood pressure, right? On the what we call cold shock, there is a narrow gradient between the systolic and the diastolic, whereas in the warm shock, in the vasodilatory shock, there is a low diastolic blood pressure. And I think that this is the key that Edgardo wanted to transmit in his lecture.
Thank you both.
Yes. He was talking about the wild. Amazing. So the next poll, Sasha, please.
Rafael.
Okay. I will read my question. Which are the main factors that determine the capability of the microcirculation to provide oxygen and nutrient to the tissues? The first option is convective flow capacity, which is determined by the flow in microcirculatory vessels and the proportion of perfused vessels. Second option is diffusive capacity, which is determined by the vessel density. The third option is heterogeneity in the microcirculation, which is determined by the existence of areas with different microcirculatory perfusion. And the fourth option is cardiac output and systemic vascular resistance. And the last option is A, B, and C, the first three options.
Yes. Here we go. Here we are.
Wow. Yes, it was easy.
You must be happy, huh?
Yes, yes. We have to remember that all of them are related, and probably the microcirculation is clearly depending also in cardiac output and systemic vascular resistance. But the direct factors that determine the capability of the microcirculatory compartment are those defining its characteristic, which is convective flow, diffusive capacity, and heterogeneity. I have a question on the question and answer.
Before you answer the question, Rafael, the reason that was an easy question for everyone was because of your excellent talk. You made it very, very clear to everyone about all three of those factors. So thank you.
Okay, thanks. So I have answered to this question written in the question and answer, and might be interesting to take a look. Sandeep Mohanty asked me, how is heterogeneity different from convective characteristics? And I have answered that the heterogeneity describes the existence of different areas with different microcirculatory conditions. You can have areas with poor flow next to areas with normal flow. And the convective characteristic evaluates only the flow. In the example, you can have a decreased flow homogeneously in all the tissues of an organ. This might be bad, but it might be worse to have an heterogeneously decreased flow. You have areas with bad flow, areas with normal flow, and these different flows result in heterogeneity and might also result on impairment of the ability of microcirculation to provide oxygen to the tissues.
Thank you very much. So it's time to give the opportunity to Edgardo Banille to introduce Juan. Edgardo.
Thank you, SASHA. It's a pleasure to present my friend Joan Sanches de Toledo, Chief of Department of Pediatric Cardiology, Hospital Sant Joan de Déu, Barcelona, Children's Hospital, Barcelona, Spain, Cardiac Intensivist and Assistance Professor, Department of Critical Care Medicine, Children's Hospital of Pittsburgh, of UPMC, Pittsburgh. He will talk present ultrasound in the cardiovascular perioperative care. Joan?
Well, thank you very much. As I said before, I will try to keep my video off for the sake of a clear connection. Unfortunately, I am on my second day of vacation in the middle of nowhere, so I don't want to create animosity among the audience, so I will not put the camera. I will talk about ultrasound and the use of ultrasound in the cardiovascular perioperative critical care. And as you all know, I think that ultrasound has played an ever-growing role in our units. It provides a rapid assessment, bedside assessment. It's accurate, and it's a non-invasive way to give complementary information to the exam that we all do in a daily basis. There is a fair amount of evidence of the use of ultrasound in other, focusing in other organs. It's not time to discuss the evidence surrounding the heart, but also the neonatologists have a big amount of experience using the head ultrasound for the last decade. What about the fast exam performed by the ED physicians? And since Liechtenstein published his book in the late 90s, the thoracic ultrasound has gained a lot of interest. And in the last 5 to 6 years, ultrasound guided vascular access has entered our units in a really rapid phase. it is obvious that ultrasound provides some important information, and this is the last updated sepsis guideline that includes the ultrasound in the algorithm. And if you think about what we do in a daily basis in the cardiac intensive care, it's looking all the organs that might be assessed one way or another with an ultrasound machine. We focus on the heart, but we look at the lungs, we assess diaphragm motion, we look at the abdomen trying to rule for ascites. We have to look at the brain because it's the really morbidity that nowadays it's impacting our patients. And then we have to do other things, right? We have to put vascular accesses, we have to check for tubes, etc., etc. So in the next 15 minutes or 20 minutes, I will try to convince you that there is a structured way to look at those things with the ultrasound. And the first thing that we have to do is understand that we have to choose and we have to pick the proper probe before moving to the examination. Essentially, we're going to use linear probes to look at the surface, that is for vascular access or looking at the pleural exam. And we're going to use the phase arrays or the convex probes to look deep in the structures, especially the phase arrays for the heart, but the convex can be also used even for the heart, the lungs, or the abdomen. And this is something very important. I'm sure that the majority of you know already those things, but I will try to go a little bit systematically. I'm going to first talk about echocardioscopy. Echocardioscopy is essentially the echocardiography performed by somebody who is not called a cardiology. And it's essentially a way to look at the heart very, 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 in a very simplistic way. We have to assess contractility, fluid status, and pericardial effusion. But if we think a little bit more deeply in what we do in terms of perioperative care in an ICU, we have to look for preload, contractility, and afterload. And if we break those three items, what we're trying to do is trying to assess the IVC. For instance, we have to look for a fluid status, but also look for Fontan circulations. We have to look for pericardial effusion, and in the way that the pericardial effusion evolves to tamponate and impedes a preload, we have to look for contractility, focusing on both LV and RV. And then we have to go a little bit farther and try to explore afterload, trying to assess AV valve gradients and insufficiencies, and also looking at the arch for residual coarctations, etc., etc. As a general rule, I think that in a four-chamber view, we have to keep in mind that the left ventricle will always look in a normal heart a little bit bigger than the right ventricle. So taking a look at morphology is important, because if I look at this picture and I see on the right ventricle being bigger than the left ventricle in the immediate postoperative period, that with a relatively good function, that has to put me in a different algorithm, diagnostic algorithm. Remember that I told you that the left ventricle is bigger than the right ventricle in a normal scenario. This echo shows a huge right ventricle, so this will be severe RV dilation, which is abnormal. And the same thing will apply in a long axis view. This is a normal long axis view with the left ventricle being bigger than the right ventricle. And look at this huge right ventricle dilated with a relatively preserved right ventricular systolic function. Essentially, what we do when we take a look at the function is eyeballing. We want to know if with a simple, quick vision to the heart, this heart is moving normally or abnormally, and that will give us an idea of how to apply our inotropes. If we take a look at this picture with a huge dilated left ventricle with an interposed mechanical valve, we know from scratch that this ventricle is not functioning. So we'll have to move rapidly to a different point of algorithm. So this is a dilated left ventricle, non-functioning left ventricle. with a quick eyeballing, we have to assess what we have in front of our eyes. It's not about quantity. It's not quantification. What we need is visualization and experience. With a rapid eyeball to the heart, we should take a look, we should know what is going on and how to intervene. I will not spend much time on the evaluation of function, but I want to mention a couple of things that are important, which is the preload assessment. And the preload assessment, again, is very simple. There is a lot of algorithms, a lot of functions, and a lot of measurements that can be performed. But at the end, we want to look if the IVC is big or if the IVC is small. Because it is obvious from this picture that this IVC is very collapsible, small, and this heart is performing very rapidly. So this patient will respond nicely to the volume. So keep things very simple when you apply your algorithms with an ultrasound machine at the bedside. Obviously, the next step is to rule out pericardial effusion. This is not the time to discuss about pericardial effusion. It's relatively easy to diagnose for any of us at this point of time. We can assess from subcostal, from long axis views, but it's relatively simple to identify at the bedside the pericardial effusion and the cardiac tamponade physiology. But we have to move a little bit forward from the initial descriptions of the echocardioscopy, because sometimes we have to assess patients that come with a really bad function. This is a near newborn, 32 days of life with severe LV dysfunction. And obviously, one of the things that we have to be familiar with is the suprasternal view, because we have to assess the arch. We have to assess the arch to look for coarctations, but also we want to look for PDAs, VT shunts, etc., etc. So we have to move one step forward and look at the anatomy and the arch anatomy on our postoperative patients. This is in this view, there is an obvious flow, a red flow returning from the arch. That means that there's a severe coarctation or a severe arch interruption. We have to keep a diagnosis very simple, because then there is the second step, which is called the cardiologist for a final diagnosis. But here we want to make sure that the audience is looking at big right ventricle with a big right atrium, and there is an abnormal shunt between the left ventricle and the right atrium. This is what we call the Gervais shunt, and this is a residual shunt in a postoperative surgery of an AV canal. So a shunt between the left ventricle and the right atrium. The next thing that it's probably even more important is the assessment of the lung. This is probably the field that has evolved more rapidly and has become more important in our units. And essentially is a matter of assessing the pleura, the amount of interstitial fluid, and looking at a little bit deeply in the parenchyma. And what we want to rule in our units is the presence of pneumothorax or pleural effusion. We want to look for pulmonary edema, and we want to look for atelectacy or consolidation in our patients. And this is relatively easy to do with a lung ultrasound, right? Because the thorax is a combination of area, is a combination of water and air, and that gives us a window on a spectrum of images that are relatively easy to interpret. And the lung signs are mainly based on the analysis of artifacts, and we don't need a really fancy machine. We need a simple two-dimensional machine that give us very simple information. And to structure the information in a very systematic way, we need to analyze in a two-dimensional exam, and look for 3 signs: lung sliding, A lines, or B lines. And if we want to proceed and analyze the end mode, we can find a couple of signs that are very, very helpful to diagnose common problems in our patients. This is the spectrum of images that we can see, from black, very black, meaning that the lung is normal, to very white, which means that there is a lot of interstitial edema. And I'll try to explain a little bit with the following 3 slides. In a normal lung exam, what we are looking at is a normal pleural line, and the repetition of the pleural lines are called the A lines. There is horizontal lines below the pleural line. If we take a look at the motion image on the screen, you see the lung sliding. The lung sliding is the sign of normal pleural movement between the areas of the fat and muscle and the lung below the pleura. So the presence of lung sliding is normal. If we apply N mode to a normal line, to a normal lung, we'll see the common seashore sign, the described seashore sign. It's sometimes a little bit difficult, and I'm going to tell you that I'm in a beach right now. That it's a little bit better than this one. And if we do the same thing, and if we do it in high frequency ventilation, look at the images. This is a courtesy from one of our friends, Javier Rodriguez Fanjul, that has this really nice image on normal high frequency ventilation, or relatively normal high frequency ventilation ultrasound. Then the presence of B lines is relatively important. B lines are common tails that arise from the pleural line and are more present. There is more B lines, the more fluid you have on the lungs, and it's a relatively easy way to identify the amount of pulmonary edema or the interstitial edema that you will have in an echo screen. Based on what I told you before, here we are looking at the ultrasound that doesn't show any lung sliding. The absence of lung sliding, which in N mode will give you the image of a barcode, which is completely different from the seashore sign, will give us the diagnosis of pneumothorax. And here you can see exactly where it changed, the movement from the area of pneumothorax, changing from the seashore to the barcode. So barcode versus seashore, it's a relatively easy way to diagnose pneumothorax in our patient population. So absence of lung sliding, absence of V lines, the presence of barcode, and the capability of identifying the lung point will give you the opportunity to diagnose rapidly the pneumothorax in our patients. It's easy to identify the pleural effusion, right? I will not spend time to tell you that those images correspond to a pleural effusion, and the more pleural effusion, the safest will be to proceed with a drainage of the fluid. And the consistency and the echogenicity of this fluid can help us guide the diagnosis. Anechoic fluid is more prone to be congestive heart failure, and deeply and thick echoic fluid might be more correlated with empyema or hemothorax. This is a nice panel also from a publication from Javi Rodriguez Fanjul, trying to grade the amount of interstitial edema on different neonatal congenital heart disease patients. And as you see here on panel A, on a tetralogy of Fallot without much pulmonary flow, there is clear normal lung with a lot of A lines. And for instance, B and C, it's transposition with more and more pulmonary edema, and you see the presence of more pulmonary edema. And finally, on a truncus arteriosus with a huge pulmonary edema secondary to pulmonary overcirculation, you see clear whited lung with tons of V lines. There's some people that say that it's relatively easy to identify the tip of the endotracheal tube. I don't find that very easy, and I'm not particularly using that in my practice, but there's certainly descriptions about that. So I guess that people with experience can talk about that a little bit more in depth. But certainly one of the things that help us a lot is the identification of the abnormal diaphragmatic motion in the immediate postoperative period. From a subcostal routine view, it's very easy to identify the diaphragm that it's not moving, and that has been described in many publications. This is a publication from one attending in Barcelona and that worked with me years ago, and that described the technique. This is the view from the axillary approach. And this is when you apply the end mode and you see a clear movement of the diaphragms towards the direction that it needs to be. Here you see on the right side of your screen a normal diaphragm on end mode compared to a left side or paretic diaphragm. Far from the lungs, we have the brain, but it's probably really important to assess the brain function. There is limited information right now that we can take at the bedside, but there's more and more people that are becoming experts. I think that at the end right now, that what we are trying to do is assess the mean flow velocity and the pulsatility index, which will give us very important information on the increased intracranial pressure. And what we look is for the reversal flow sign. And here, for instance, is a patient that developed after surgery on ECMO a head bleed and progress in relatively rapid to a brain death. And you can see how the reverse sign after 24 hours, it's easily identified. I am not an expert on head ultrasound, so we'll move to a couple of things more. It is obvious that the ED people has used the FAST exam, the focus assessment with sonography for trauma, as a part of his exam. Here in an ICU environment, we use that to assess ascites and to assess the Foley catheter position and the bladder contain. It's relatively easy, and it can help us direct our procedures easily. One of the things that I want to spend a couple of 5 minutes with is the ultrasound guided vascular access. That has probably changed the way we practice medicine over the last 10 years. I remember when we started to use it back in 2005, 2006. And people was not trusting our capability, but now things have changed, and it's relatively difficult to see a new trainee accessing a vessel without the use of ultrasound, which is also a problem, but it has helped us a lot to decrease the morbidity in our patients. The reason why is obvious. There is anatomical variability in a very different position compared to the previous patient. And even if you change the position of the head, you are implementing a structural change on the relationship of your vessels that might distort anatomy and create a lot of problems when you try to access a vessel. And obviously, what we are trying to do is to avoid complications. The complication which happens more often when we try to access a vessel is the posterior wall puncture, and this is a routine complication when you go blind. But also what we have done, and I am the first one to admit, we have a cannulate the carotid artery, trying to cannulate the vessel. So there is a lot of complications that can be avoided with a systematic approach. A systematic approach that it's published, it's elsewhere. I want to reinforce the idea that we have to always use sterile measures to access our vessels. And here in the screen, you see a properly performed procedure following all the sterile measures. Last but not least is training, right? There is a lot of opportunities to train. We want to avoid the training on our patients, but the problem with the mannequins is that are expensive. We have used some other homemade phantoms that have give us a lot of important information, and we have used to train our fellows with good results. And here you can see how is it perform a procedure with ultrasound guided, approaching the vessel in a longitudinal manner, accessing the vessel, avoiding the posterior wall, and confirming the presence of the torque wire inside the vessel on a longitudinal axis. And finally, I want to summarize with a couple of slides, trying to put together all what we have learned and see if the ultrasound can be really applied in a cardiac arrest environment. We all know that the cardiac arrest situation is complex, and sometimes the last thing that you want to put is an ultrasound machine inside a room where cardiac resuscitation is ongoing. But I think that there is enough evidence that will tell us that an ultrasound machine apply with somebody that has some basic knowledge and a systematic approach will give us important information. We have to assess the heart, we have to assess the lungs, we have to assess the abdomen in a systematic approach with a systematic views, trying to simplify the amount of views that we're going to do using only one probe. With our experience, we know that with the phase arrays or even with the microconvex, we can access heart, lungs, and abdomen in an easy way. And it's simple. If we go into an arrest situation and we put the probe and there is no function, like this one, you have to move fast, right? So either you stop resuscitation or if you call for ECMO. If you don't have ECMO, it's going to be unfortunately, but this patient will probably not move forward. But then if you have ECMO capability, you move forward. Then if you find heart motion, you have to try to puzzle yourself and see if you can see hypovolemia, if you can rule out tamponade, or you can rule out other things. So for instance, this is a classic video that I have put in other presentations. This is a resident with no previous experience on ultrasound that was giving us information through his mobile phone on this postoperative patient, and this is obvious pericardial tamponade as a source of a cardiac arrest. We talk about that. When you see a right ventricle, you have to think about other things. Right ventricle that doesn't function, you have to identify things. This is a pulmonary embolus, a thrombus in a postoperative a RV2PA conduit. Remember and discriminate between hypovolemia and hypervolemia and rule out pneumothorax, right? We know that the VAR code will give us information about the pneumothorax, so it's relatively easy. No lung sliding and VAR code will be pneumothorax. So try to puzzle yourself, try to apply rapid algorithms. If there is heart motion, If there is no hard motion, call for ECMO on stop resuscitation. If there is hard motion, try to differentiate if there's a pericardial effusion and a dilated right ventricle, you are probably in front of a cardiac tamponade physiology. If your right ventricle is very flat and there is no there is a hyperdynamic LV, probably what you have to do is to give volume to the patient. If instead your right ventricle is very dilated and there is no flow going to the left ventricle, perform a lung exam, rule out for pneumothorax. If there is no pneumothorax, you have to think about thrombus in the lungs. And if there's normal function, normal lung exam, you have to keep thinking, keep going, and keep thinking. So in conclusion, I think that ultrasound is playing an ever-growing role in our pediatric ICU environment. I think that ultrasound should be included as a complementary tool to the physical exam in our a routine check in a perioperative setting. But remember that incorporation of the ultrasound in the CICU is only a small part of this big subspecialty. And this is all what I wanted to tell you, and I will be happy to answer any questions that you may have.
Thank you, Joan. It was a very good, comprehensive talk. We learned a lot, and I really hope that it is going to incentivize our colleagues to start to use more cardioscopy and lung ultrasound in the CICU settings. It's not very common. Every PCICS meeting, we have a ultrasound, a POCUS course, a training course. So I think people need to start to use it more because it gives a lot of good information to all of us. Thank you for your presentation. So now moving on, we are going to have Dr. Korbin Haycock. He is an emergency medicine physician with a special interest in point of care ultrasound and echocardiography for use in resuscitation and critical care. He is the assistant professor of emergency medicine and pediatrics in Loma Linda University School of Medicine. And he works primarily at Riverside University Health System Medical Center, where he is the emergency department director of education, critical care resuscitation, and ultrasound. He is the co-developer of the VEXUS Score, which is going to be the topic of our next lecture. Thank you very much. You need to unmute, please.
Okay, sorry about that. Okay, thank you for the opportunity to talk to you guys. I do, sorry, having trouble advancing. Yeah. Okay, I have no disclosures or conflicts of interest. I think a lot of times when we're thinking about the macro circulation as opposed to the microcirculation, we're considering perfusion in terms of what's the mean arterial blood pressure. And we need to remember that there's downstream pressures that are generated by the venous pressures and congestion that actually can decrease flow and perfusion to the vital organs. And so, you know, remember that the driving pressure is whatever the pressure is on, you know, the capillary arterial side of the vessels, and the higher the pressure is on the venous side, the lower the flow is going to be through there. So this actually is a real clinical entity with significant consequences. There's been a lot of recent work done on portal hypertension and the effect of gut edema, since that's the primary venous drainage of the gut. It's associated with lots of endotoxins and inflammatory cytokines associated with chronic congestive heart failure, gut dysfunction, as in malabsorption, malnutrition, and if you're trying to treat things with venous congestion with things like Lasix, decreased medication absorption. It's been known for about 20 years in a lot of the literature, but even before then, that the venous congestion can cause a lot of renal dysfunction. Clinically, what I see a lot of times is a lot of talk about when you see the creatinine rising and the kidneys not functioning well, it's thought that this is low flow state to the kidneys. But it turns out that most of the time it's actually more to do with congestive renal dysfunction and high right atrial pressures congesting and decreasing perfusion of the kidneys. And the kidneys don't care why they're not perfused. They assume that it's a low volume state and routine sodium and water. And in the ICU population, it's probably pretty unrecognized that a lot of the encephalopathy is related to congestive encephalopathy and high venous pressures. I think it's useful really quickly to review the differences between the arterial and venous side of the circulation. The arterial side of the circulation is characterized by very pulsatile flow, where you have a very high systolic peak pressure and velocity, and then the elastic recoil does the diastolic runoff. The arterial system is characterized by very high elastance, low capacitance, and high resistance. As you drop down nearer to the smaller vessels, you lose the pulsatility, and you will get a more phasic, sort of steady, non-pulsatile flow through the capillaries. And if we then look at the the venous side of the circulation, if we look at what's going on near the right ventricle and the right atria, we actually have a pulsatile venous pulse here that can be measured with Doppler or catheters, and it has to do with flow dynamics from the venous return into the right atria. And normally, because the venous side of circulation is characterized by high capacitance, high compliance, in contrast to the arterial side, as we get to the smaller vessels, that compliance tends to dampen the venous pulse. But when we get more venous congestion and the pressures start to rise, we start to stretch out these smaller vessels. And when they start to get to the limit of their capacitance, then that pulse, venous pulse, gets transmitted back farther, deeper and deeper into the parenchyma, and we can actually measure this, and it correlates with venous congestion of the organs. So with the venous Doppler, I think most people are not really too familiar with it. The velocities tell us things about flow and pressure, and also the pattern of the velocities and how they change over time can give us information about two things. If we Doppler a vessel that's near to the right atria, it gives us information about right ventricular function and how it's actually, how efficiently it's dealing with the pattern of venous return that's been driven by the distending pressure or the mean systemic filling pressure or from the stressed volume of the smaller veins sending blood back to the heart. And then secondarily, if we would Doppler the vessels that are deeper, far into the parenchyma of the tissues, this gives us an idea of venous compliance. So it's a key thing to realize here that venous congestion can be a function of either right ventricular dysfunction or inefficiency, or it can be volume overload of the patient. So our three prototypical vessels that we would Doppler would be hepatic vein Doppler. So this is close to the right atria, and this is where we would see a lot of these venous pulsations and make inference over what is going on with the right ventricle and how it's dealing with the venous return. And then portal vein Doppler is sort of the prototype for looking at the venules and when we've reached the limits of venous compliance in the systemic organs. There's other ones we can Doppler too, but this is the best studied, I believe. And then if we look at the intrarenal vein Doppler, it's sort of a hybrid, as I'll show you, between the hepatic and portal vein Doppler, or the sort of the right atrial signals we're getting versus the compliance. So start off with the hepatic vein Doppler. This is basically the flow either to or from the right atria. And the baseline is basically the mean systemic filling pressure, that pressure that's being driven by the distension of the stress volume on the venous system. And so that's going to be squeezing towards that. And anytime that our right atrial pressures drop below that pressure, we're going to have flow into the hepatic vein as reflux. And every time those pressures drop, the right atrial pressures drop below, we'll have forward flow towards the right atria. So if we look at an EKG, we'll have with atrial contraction, some of the blood goes forward into the right ventricle, but some will reflux back because there's no effective valve between the right atria and the vena cava. And so we'll get a positive deflection, or meaning flow refluxing into the hepatic vein. Then during systole, a number of things happen. The first thing is that the pericardium is covering the heart, and it's relatively non-compliant. So there's only so much room in each of the chambers for blood. So when the blood empties out of the right ventricle, there's more room in the atria. Also, the tricuspid annulus is rising up towards the apex of the heart during contraction, and that's tending to move blood up in. But most importantly, we have atrial relaxation, and that is augmenting forward flow from the vena cava and into the right atria. And so we get a very high flow towards the right atria during systole. And then as the right atria fills and it becomes less compliant, we'll have our V wave, and then the tricuspid valve opens during diastole, and the right atria becomes a passive conduit for blood flow right through into the right ventricle that's relaxing and suctioning blood into it. And so a normal pattern would be a not so big A wave, of S wave larger than the D wave, and a D wave that's a little bit smaller than the S wave. And I'm sure that most of you have realized that this is basically your jugular venous waveform, with the A wave, S corresponding to the X descent, and D corresponding to the Y descent. So how do we Doppler the hepatic vein? There's basically two ways that are quite easily attained in most people. The difficult part is when there's a lot of respiratory variation. But if you go from a subcostal, like you get from a subcostal 4-chamber view of the heart in echo, and just rotate that probe a little bit counterclockwise so that the beam is oriented in a cephalid to caudad orientation, and then just drop the pulse wave Doppler gate. You want to use a pulse wave Doppler gate over the hepatic vein near to where it dumps into the IVC. This is a transverse view, not a longitudinal like I just described to you, but it doesn't matter. And then the other view you can sometimes do if you can't get an adequate subcostal view is just move over to the anterior axillary line, and you can normally Doppler the right hepatic vein from there. So the pattern as we go from good RV function and no venous congestion to venous congestion and bad RV function is we have a smaller A wave, an S wave, the key thing, the S wave being bigger than the D wave, okay? And then as the right atria loses its ability to relax as well because it's distended and a little congested itself, you'll get a large A wave as more blood is refluxed back up into the hepatic vein during atrial contraction. We lose the atrial augmentation of the S wave. So the S wave then becomes less than the D wave, okay? And then finally, this S wave gets smaller and smaller and smaller, and actually reverses in severe congestion, and then turns in, it fuses with the A wave. And so we've gone from this biphasic tetra-inflectional wave to a tetraphasic tetra-inflectional to a biphasic flow wave. And so here and here we can get a little bit confused. So I would really strongly advise people to run an EKG lead so that you don't get confused between these two waveforms. Okay, so now onto the portal vein. So just to review, the circulation to the liver is 80% portal vein and about 20% hepatic artery branches. And these travel in the hepatic or the portal triads, and the artery and portal vein dump into the hepatic sinusoids next to the hepatocytes where all the biochemistry happens. And they trickle down into the hepatic veins, which ultimately join up and drain into the IVC. When we run into situations where there is high venous congestion, the pressures are transmitted up back into the sinusoids, and normally these can dampen the venous pulsations that are there in the hepatic vein, and the portal vein as well will dampen it by nature of its high compliance. However, when the congestion gets bad enough, we lose the dampening ability because they're stretched to the max, and then we can get some of these hepatic pulsations detected in the portal vein. The portal vein of all these is the easiest to Doppler, and basically just go from an anterior axillary view. The portal vein will divide right after the porta hepatis into right and left branches, and the right branch usually comes directly at your Doppler gate. So it's a very good, easy vessel to evaluate. So this will behave like a small vein normally, with just kind of undulating, phasic, nice, easy, rolling, gentle flow. And then as the venous compliance reaches its limit, we start to see some pulsations that are related to the back pressure of the A wave being transmitted. And ultimately, when the S wave reverses, we get very big pulsations, and we can actually get a biphasic look to the portal vein Doppler. Finally, intrarenal vein Doppler. This is the most challenging of these Doppler exams. So we want to not Doppler the actual renal vein. It will basically look exactly like the hepatic vein. And we want to avoid these larger veins in the kidney. The smaller interlobar veins, or there's arcuate veins that come up this way, in between the medullary pyramids is where you would want to Doppler this. This Doppler is a little bit off here, but ideally you'd want to do it high up in the renal parenchyma so that we get the smaller venules. And when we Doppler the the intrarenal vein, we get actually a signal here. This is the baseline, and the small arteries are traveling anti-parallel to the small veins that we would be interested in. And so above the baseline is the arterial flow coming towards us. And from the difference between the peak velocity and end diastolic velocity, we can calculate a renal resistive index, which we're not going to talk about today. Just know that the bigger the difference between there, the worse the microcirculation probably is in the kidney. But below the baseline is the venous flow running away from us. And just like the portal vein, it should be nice, slow, rolling, undulating flow. But just like we saw in the portal vein, when the vessels start to become stretched from venous congestion, we start to see the flows become pulsatile. And then finally, it starts to reflect what's going on with the hepatic vein, where we have an S wave during systole and a D wave during diastole. And this S wave will become smaller and smaller and smaller until it actually disappears and is hidden behind the arterial flow pattern. And we're left with only an interrupted diastolic only flow. And so each of these has an advantage and disadvantages. The hepatic vein Doppler is going to give us information about RV function that we wouldn't necessarily get from portal vein or intrarenal venous Doppler. There's a wealth of information that can be found in these waveforms that's beyond the scope of this talk. The disadvantage to hepatic vein Doppler is that if you are in a situation where you have significant tricuspid regurgitation, but no volume overload, that S wave will still reverse. And so it may be a false positive. Portal vein Doppler is technically very easy. The most bang for your buck. It's highly informative of venous compliance. However, there are a few false positives in young, healthy individuals. You can get quite pulsatile flow when there is no venous congestion. And in fatty liver or in cirrhosis, the liver tends to dampen the pulsations, and you can have a false negative. The intrarenal venous Doppler is very specific for renal congestion or renal sarca. The main disadvantage is the technical difficulty of doing the intrarenal venous Doppler. You're not going to be able to get it in maybe about 15 or 20% of people. So venous congestion, a lot of the groundwork had been done with Doppler in the portal vein by Andre Banille and his group. Some of us were interested in this and also interested in the other organs, and some of the work had also been done in that. But we wondered if perhaps we could come up with a scoring system combining these three prototypical Doppler exams and see if it would predict clinically meaningful outcomes in patients. So Dr. Banille and his group had a database and exams that they've been doing. They had what we looked at was these were adult, not pediatric patients, but adult cardiac surgery patients that underwent what we call the VEXUS exam or venous excess with ultrasound exam, pre-op, intra-op, post-op, post-op day 1, post-op day 2 and 3. And we looked at different combinations of if the IVC was dilated, normal versus abnormal patterns, mild versus severe abnormalities. And we then looked at kidney injury because we chose that because it is pretty clinically relevant to a patient-oriented outcome, and it's pretty common in the ICU. So what do we mean by normal, mild abnormality, and severe abnormality? As far as the hepatic vein Doppler goes, S greater than D is normal, S less than D is mild abnormal, and S wave reversal is a severe abnormality. The portal vein, a mild abnormality is 30 to 50% pulsatility, and severe abnormality is more than 50% abnormality, or biphasic if it drops below the baseline. Intravenous Doppler is when we get to the discontinuous where it reaches the baseline, S and D wave is a mild abnormality, and diastolic only flow is a severe abnormality. This is based on some of the cardiac literature that shows a very significant mortality difference and hospitalization rate when you run from this renal pattern to this renal pattern. And so we wanted to compare if combining these scores worked better than any of the exams in isolation, and then also the most common probably venous congestive hemodynamic variable being the CVP. And the VEXUS score was highly specific for developing a kidney injury with a pretty good likelihood ratio that outperformed any of the portal Doppler, hepatic, or renal Doppler in isolation, and also outperformed right atrial pressure, or CVP, as a measure of venous congestion and kidney injury. Here's a leaf plot comparing the highest CVPs versus VEXUS score with grade 3 congestion. Basically that, I just didn't tell you on the other slide, is basically it's defined as a dilated IVC and at least 2 of the 3, the hepatic, portal, or intrarenal venous Doppler, at least 2 of the 3 being severe congestive pattern. So Dr. Edgardo Banille had showed me this case, and I want to try and show you how this might be relevant to congenital heart cases, since this is what this conference is about. This was a 13-year-old female who had Ebstein's anomaly combined with obstructive left heart disease due to both aortic stenosis from a bicuspid valve and aortic arch hypoplasia and coarctation. At 15 days, she'd gotten a balloon angioplasty, although developed recoarctation at 6 months. Further developed severe fibromuscular subvalvular stenosis, which is pretty high trans LVOT gradient of 110 millimeters. At 1 year, she had a septic aortic, she received an aortic commissurotomy and wedge resection of that subvalvular stenosis. And the Ebstein's was just treated conservatively. Annual checkups were unremarkable for any worsening of the tricuspid regurgitation, which was only mild. So at 13 years later, she presents to the clinic with about 2 weeks of new onset edema of the lower limbs and dyspnea on exertion, which was new. If I understand correctly, then the labs that day were with not too bad renal dysfunction. It's there though, and there was proteinuria present, and so there was a concern for there being a component here of a nephrotic syndrome that was developing. The urine studies the next day were abnormal, but not quite diagnostic of a nephrotic syndrome. The echo showed no recoarcation. There's mild AR, basically nothing on the left circulation. The right ventricle had ghost 2, mild M mode tricuspid annulus travel distance abnormality, 15 millimeters, and tissue Doppler of the lateral annulus was 8 centimeters per second, which is probably slightly low. The diastolic dysfunction was there in the right ventricle, and now the patient had a dilated IVC with very little respiratory collapse and severe tricuspid regurg. So Dr. Banille had Dopplered the hepatic vein here, and unsurprisingly, because with Epstein's we would expect most of these patients probably to have significant tricuspid regurg, there is a biphasic hepatic vein Doppler. So this doesn't necessarily prove that we have venous congestion, but then we go into the parenchyma and see if the liver is feeling it and the organs could be feeling it. And sure enough, the portal vein is highly pulsatile. This would be severe pulsatility of the portal vein. And so now with this in our VEXUS C scheme, we already are a VEXUS 3 score, which is the most severe. However, if we look at the intrarenal venous Doppler, we also have a severe flow abnormality there too. So doing this exam actually made them suspect that this was a new onset cardiorenal phenomenon going on, and the venous congestion was the cause of the kidney dysfunction and the edema. And the patient then had diuretic therapy and had a significant improvement in their clinical status. Now, this VEXUS study was done on adult patients. I do think it probably has applications for pediatrics as well, but there haven't been any studies done yet. How can we use this? Well, I think most directly because this study was done in the setting of cardiac surgery patients. You can do a pre-intraoperative or post-operative interventions to optimize your hemodynamics by checking for venous congestion. Myself, I'm using this a lot in my resuscitative guidance. If I have a shocked patient and I notice that there's venous congestion, my investigation then goes to some Doppler evaluation of why the right ventricle is not performing. So I might consider what the pulmonary vascular resistance is. Is there any right ventricular arterial uncoupling that I can detect with echo? Or is this a volume overload situation? And they need diuretic. So this is very helpful in resuscitation. And also in things like sepsis, a lot of people are throwing a lot of fluids at these people, and this can help guide us as when we've given enough fluids and it's time to go on to another strategy. Also, I know that there's a number of clinicians out there now using VEXUS in their outpatient heart failure clinics to guide diuretic therapy and to sort out if it is congestive renal injury or a cardiorenal situation going on, or if there is an overdiuresis happening. So with that, I thank you for your time and attention, and I'd be happy to answer any questions.
Thank you very much, Korbin. I think that your point of care must be it's very interesting, and I'm sure it will be very useful in the ICU, PCI ICU, also, of course, also in emergency. And thanks for the case you present. It's a very challenging case for us, and I'm sure the people will contact you, and you will be able to answer to most of the question, because it's very interesting. I'm sure it's a preliminary way to approach, and as a pioneer, you need time. But we are here to help you in this, trying to keep your idea to all the intensive care. I'm sure it's very interesting.
I appreciate that. Yeah, there actually is a number of articles in press using the VEXUS score in general ICU populations as well, and basically show this, the same findings we found in these post-cardiac surgery patients.
Thank you very much, Korbin. It was we received a lot of information, and people on the chat also thanks you. So if you want to answer, it will be a pleasure for them. So we go now to the last speaker, is Dr. Pablo Motta, that has practiced medicine for more than 27 years. After earning his medical doctor from UDELAR School of Medicine in Montevideo, he went to specialize in adult and pediatric cardiac anesthesia holding position both in Cleveland Clinic and Baylor College of Medicine. Now he's an associate professor with Baylor, participating at Texas Children's Hospital, also in Houston. And it's Dr. Motta leads in the area of anesthesia and heart and lung transplantation and adult congenital heart disease. And actually is the associate medical director of Heart Center International program, directing also mission trips and advising in several congenital anesthesia. It's my pleasure, it's a real privilege to introduce such an interesting and important topic like NIRS monitoring in cardiovascular perioperative. Dr. Motta, it's your moment.
Hi, good morning, actually good afternoon. I think there's people even in the evening, so good evening for our attendees and the panel. So I'm going to talk about NIRS. I have nothing to disclose. I work at Texas Children. This is our congenital anesthesia textbook. We're working on the 4th edition. So that's just a little advertising here. I have to thank all the organizers here, Grace, Salvatore, and Gil for the invitation, and the panelists that are here with me. It's been outstanding, so I'll try to follow, and this is all like continuing, even though we have different talks. I think it's all for the better care for the congenital patients. So I'm going to try to make it simple. I want to talk a little basic principles, talk about the limitation of this technique, how we use it clinically here at Texas Children, what's the available evidence, and what do we see, what will happen in the future, even though we don't know, things changed this year a lot with COVID, so things could change also. And why are we talking about NIRS in congenital heart surgery? There's a fair amount of evidence in adults and children with congenital and non-congenital that undergoing heart surgery has a risk for neurologic complications. And this is a landmark article by Dean Andropoulos, who is the chairman at our department, about the incidence of neurologic complications. And back then in 2004, he was trying to go over how to monitor these patients, neurologically monitor these patients. So NIRS has been available, since the early 2000s. And essentially, the principles behind it is the wavelength absorption of two different chromophores, the oxyhemoglobin and the oxyhemoglobin. And that gives you a number which displays the cerebral oxygen saturation. And that's something easy to be followed in the ICU, in the perioperative or post-operative in the ICU, or in the operating room as we do it. So there's several equipment brands of oximeters. We do use INVOS at Texas Children. There's a fair amount of publications with others. I'm going to mention a couple of studies that they use Foresight. And this technique has been improving through years. And as you could see, as part of our monitoring in the operating room, we have the hemodynamic monitoring, we have the ventilator, and the NIRS as part of our setup, all being fed to the electronic medical record. So we do monitor NIRS in the ICU, and we do monitor NIRS all through the surgery and also in cath lab interventions. So essentially, the principle is the spectroscopy measures cerebral oxygen saturation is the ratio between the oxyhemoglobin and the oxyhemoglobin plus the oxyhemoglobin. The question here and the concern is, what are we measuring? Are we measuring the skull, some shallow tissue, or we're measuring the oxygenation at the cortical level? That's what we're interested in. And that's where this technique has some assumptions. Depending on the equipment that you're using, there's going to be an assumption that there's going to be mostly venous blood, and some arterial in a ratio 7:30, 75:25. And that's how the number that's going to come on your screen is going to be the combination of that arterial content and venous content. What's being shown in the literature is that that's not fixed. As you all know, the brain is very reactive to CO2. So in situations of hyper or hypocapnia, the content will vary in terms of the arterial and the venous. So that could be a problem if you were based on this 70-30 assumption. So actually, this year, last year, there was a editorial article by Jim Dinardo from Boston about oximetry in children. And the question he brings up, are cerebral oximeters measuring what we think they are measuring? And we're going to finish the talk with the article he was referring. So the importance of validating each of the systems, the foresight, the invoice, with capillary pressures, jugular vein pressures, arterial pressures, and see how much they do correlate. There's different algorithms in the correction. So essentially, we follow this as a trend through the procedures and see the effects on the interventions we do. So the important thing here is try to get all the noise, all the artifacts, and subtract that to give us a reliant number on the regional cerebral perfusion. That's what we are interested in. So what this engineers do, they add different detectors at multiple distance and try to, wash out all the noise and keep us with a reliant number on. That means that we're actually monitoring the cerebral cortex and not shallow structures. So the clinical use, how do we use this system? And this is actually, it comes out Andre Denault from the previous talk. He's very versed in ultrasound, but he's one of the pioneers with Morgan from Canada about the use of cerebral NIRS in cardiac surgery. They did this is an adult population of cardiac surgery. They have a stepwise approach of how to troubleshoot cerebral oximeter desaturations in cardiac surgery. So taking their approach, we do similarly in congenital, even though some things obviously are fairly different. In children, we don't have arteriosclerosis, we don't have emboli, we have more hypoperfusion. So the first thing when we are seeing a cerebral desaturation, either in the ICU or in the operating room, we look out of cannula malposition, especially if you have an ECMO patient or a patient on bypass. Is the cannula favoring one side versus the other? Is the desaturation symmetric or asymmetric? If desaturation is asymmetric, most probably is a flow-related phenomenon versus is a bilateral, is probably hypoperfusion. How is the SVC? Is the SVC may be obstructed with the ECMO, bypass cannula? You have an increased CVP pressure. This could be a failure. We just saw a case of Epstein, who probably will have very high CVP. If you have a transplant or a PAVPAR surgery, that you could have an SVC stenosis, or what we see commonly in congenital failing single ventricle physiology. So that'll be step one. Step two, how's your pressure or your flow? There's always a discussion in congenital, and when you're running bypass or ECMO, what will you favor? A target pressure or a target flow? We have an outstanding talk about microcirculation. So in our bypass approach, we favor high flows, and we use a fair amount of vasodilation and even phentolamine in infants, targeting high flow, 150 mL per minute per kilo patient. So you have to secure that you have good perfusion pressure, but also you have good flow. And that will affect your NIRS. What's your systemic oxygenation? Are you desat for some reason? you having right to left shunt, you have shock, or the flows are not adequate, either you're on an assist device or an ECMO. What's your PCU2? If you're in the ICU, you have to optimize the ventilation. If you're in the OR, we manage our gases on bypass, especially when we're cooling, using permissive hypercapnia to improve cerebral perfusion. So that's important to follow your gases while you bypass if you see cerebral oxygen desaturation. Hemoglobin, here you see a case when the arrow, you go on bypass and there's a profound desaturation. You have to have been clear what should be your threshold for transfusion, either in the OR or in the ICU, especially in cyanotic patients, which they won't tolerate hemodilution as much. And you can see here, same patient going on bypass on a clear prime. The first crit is down to 19, and post adding blood to the circuit, the cerebral oximeter re-levels fairly quickly. Then you have to look in the cardiac function. We have an outstanding talk about ultrasound echo. When you win in bypass or you're in the ICU, you have to see how the heart function is. You may need to add inotropes, and that will improve. Here I have a tracing of a somatic NIRS and cerebral NIRS, cerebral on top, and it's a patient undergoing a chest closure. We do a fair amount of bedside cases in the ICU. Chest closures in neonates, many times they leave the OR with open chest due to hemodynamic instability or marginal ventilation, and eventually we close this patient in the OR. And one thing we use in the decision making is the NIRS, somatic and cerebral, and see how they do tolerate chest closure. If we see cerebral desaturation or somatic desaturation, we may not do the chest closure, or we may increase the dose of inotropy, or we may transfuse, try to see how much it can be tolerated by the patient. The other thing that we look into is how much the brain is consuming. On and off bypass, we're very careful cooling and rewarming the patients, trying to make an even cooling and even warming, keeping a gradient less than 8 degrees centigrade. So we allow a good cooling and protecting of the brain, and even warming as well. What the anesthetic levels are, we have decreased NIRS, maybe the patient's too light, maybe the patient's inadequately sedated in the ICU. And the final thing is, what's the flows? And here I have 2 pictures of a balloon heart in the bottom and a hardware. How is your cardiac output? Is it pulsatile, not pulsatile? And if you provided enough cardiac output to this patient. So the group from Merkin, they eventually test their algorithm. They describe on a paper, and then they test, and they showed that the monitoring cerebral regional saturation in bypass patients avoids desaturation. The question is, desaturation will, avoiding desaturation will improve the neurological outcomes. That is what we are interested. This is also an old paper from our service by Dr. Fraser and Dr. Andropoulos about anterior cerebral perfusion and the role of NIRS. And as you see in 9, we try to keep, when we're doing anterior cerebral perfusion, maintain the oxygen saturation within 10% of baseline. And if we fail to do that, we do the interventions that we previously mentioned. This is an interesting study about what's the value of NIRS in cardiac surgery, in pediatric cardiac surgery, in terms of outcome. And they found on a multivariate analysis that desaturation below 50 predicted a longer ICU stay, hospital stay and mechanical ventilation. It was only a single center study, but there's more evidence trying to address this issue. So the authors conclude that increasing saturation below 50% and increased variability on the regional cerebral perfusion is associated with longer ICU, hospital, and mechanical ventilation after the correction for confounding factors. So just to finalize here and be open for questions. So what you see as the future, and this was the article that Jim DiNardo was referring on the editorial, is validating what they call the second generation of NIRS devices. And this is a very comprehensive study by the group from Boston with Dr. Nasser. They used Foresight, and they did this in the cath lab. Doing this in the cath lab allows you to do sampling of oxygen saturation pretty much anywhere, in the jugular vein, mixed venous, arterial, and correlate with the cerebral oximetry. In this case, they use the Foresight Elite, and they show a very good correlation between the Foresight and different measurements in jugular vein, mixed venous, in cyanotic and non-cyanotic congenital patients. So we need to look more into validating of these different systems so we can rely on them, and more outcome studies to see if the use of NIRS, not alone, with intervention, can improve the outcomes, neurologic outcomes after congenital heart surgery. And this is my email and my Twitter account, and I think we can open it for questions.
Thank you, Paul. It was amazing. I really, as a surgeon, I really believe that we have to improve this technology, because I think that the first generation, as you say, there is now a second generation, make a big, it starts something new in the monitoring of the patient. But you know, sometimes there is a big skepticism of this type of device. So I'm sure the new generation can increase the level of utility and usage of this device. When we start with the brain monitoring, then now we move also to the kidney monitoring, or it means abdominal monitoring. So I'm sure that something is moving. The patient, probably for the neonates, we have a very important impact of this type of technology. But the second generation, we expect a lot from the second generation. I don't know what is your personal opinion about this.
Yeah, I think the main thing here is that we cannot ask the monitor to improve the outcome. The monitor will allow us to detect a problem, but how we address a problem is what's going to change the outcome. It's similar discussion with the Swan-Ganz catheter, and we can go back to that like 25, 30 years ago. It's not having a Swan-Ganz going to cure you. It's what, when you get that data, what you're going to do about it. So I think that's the key, is develop intervention protocols. What are the triggers for intervention? And have buy-in from all the stakeholders, cardiology, ICU, surgery, anesthesia, perfusion. Everybody should be in the same boat, because if I do one thing and you don't do it, and the ICU does, I don't think it's going to change the thing. I think it has to be a whole heart-centered approach. So are we going to use this monitor? When we see these flags, what are we going to do? And eventually, the other thing that is being in the make is autoregulation monitor based on NIRS and blood pressure, and also targeted intervention. We know that newborns don't autoregulate well. How are we going to approach that? Is it going to be a pressure-driven approach? Is it going to be a flow approach? There are many, many, many variables that we have to control. I think, you know, having a good understanding from the whole heart center and targets to intervene, I think that will be key. That's how I see the near future.
Yes. Thank you. There is some comments from the panelists. I don't know. If we want, we can. Sorry.
We have 3 more questions on the pool. Do you think we have time for that?
Yes. We have one from Korbin. If you can read your question.
The VEXUS evaluation uses point-of-care ultrasound to assess for venous congestion and predicts mortality in adult post-cardiac surgery patients, has been shown to be more specific than central venous pressure to predict acute kidney injury in adult post-cardiac surgery patients, can be used to predict volume responsiveness, uses splenic, femoral, hepatic Doppler to assess for venous congestion.
Yes. People is answering. We wait a few seconds. Yes. Are you happy with this answer?
Yeah, so the correct answer is that it's been shown to be more specific than central venous pressure to predict acute kidney injury in post-cardiac surgery patients. The issue of volume responsiveness is an interesting one. This is kind of a little bit of a tricky one here. If you have no signs of venous congestion, then should you give fluids is I guess where people are going with that. The way I put this in my mind is I first, before giving fluids to any patient that I'm trying to resuscitate, is I assess to see if the right ventricle is going to deal with that fluid in a positive manner. In other words, increase my stroke volume or my cardiac output. So if I have a big dilated IVC or my hepatic vein Doppler or looks like the right ventricle is not working well, or I have a dilated right ventricle or my TAPSE is low or something like that, then I'm going to hold off on fluids and I'm going to call that patient volume intolerant. If I've ruled out my volume intolerance, then I'll check for volume responsiveness. The IVC is a little bit fraught with trouble to do volume responsiveness. It performs about as well as the right atrial pressure. And the reason why that is because a dilated IVC is indicating to you that your right atrial pressures are close to your mean systemic filling pressures. In other words, there's not much of a gap there between the venous return pressures versus the inhibition to that. So when you see a dilated IVC, they're probably not going to be volume responsive, although they still could be. And when you see a very flat IVC, there is a high probability that those patients will be volume responsive. But then we come into the question of is, well, for instance, if I'm dealing with a distributive shock patient and my systemic vascular resistance is like 500 and my cardiac output is say 9 or 10 liters per minute, I'm talking about adult patients, low SVR, high cardiac output. Do I need to increase the cardiac output? Because as Edgardo's demonstrated, in his lecture, you can have a very high SCVO2 and still have tissue hypoperfusion. And the reason why is because it's a distributive shock where the problem isn't flow. It's actually that for some reason the tissues are not utilizing the oxygen. So it's a very complex question what to do with volume responsiveness. I wouldn't recommend using just the venous side Doppler as a go ahead to give fluids. I would assess with a straight leg test if my cardiac output goes up or stroke volume goes up or something like that. I would more use the venous as a stopgap of no more fluids. Let's try and treat this shock with another strategy. And then I don't remember what my last one was there. I was going to comment on the people that had answered that question.
Sorry, wait. This one.
Oh, so yeah, the prototypes that we used in the VEXUS was actually not the splenic, femoral, or hepatic. It was the hepatic, portal, and intrarenal venous Doppler. So any of these actually could theoretically be used. And I'll tell you that the femoral vein actually is turns out to be pretty useful for assessing venous congestion on its own as well. So just kind of point out that there's other ways to skin this cat.
Thank you very much. It's very clear now. I think that we have now the poll from Pablo. Pablo, if you read to your people, please.
Sure. My question comes in regards to the relationship between venous and arterial blood in the intracardial light path that contributes to the total cerebral blood volume. Which statement below is correct? Is a fixed ratio 70/30? Is a fixed ratio 75/25? Is a fixed ratio 80/20? Or is a variable with conditions of hyper and hypocapnia?
No, I want to only stress the concept that, as you know very well, the use of NIRS in selective cerebral perfusion changed the story, I'm sure, for this type of application. So I really believe that, as you say, is a team approach to the device or to the tool, is not a single person or a single establishment like anesthesia or cardiology or cardiac surgery. And the study from Vivian Nasr, as you say, is a big example of this approach, because, as you say, was done not in the theater, but was done in the cath lab. So this is a real, real life, rather than, because cardiac surgery is, I think, is too much variable. But cath lab sometimes is more stable patient. So I think it's a very good idea to use in the cath lab. We are now finished. I will share results. Tell me if you are happy or.
Yeah, I'm pretty happy. I think the key concept here is that the brain reacts to hypocapnia. And it's pretty important when you start these cases, get a good baseline value and try not to change too many variables. So if the patient allows, you can do this with the patient breathing spontaneously in room air, but sometimes in children, we know that that's difficult. So after intubation, we'll let the patient stabilize, we check gases, and be sure that the patient is not hypoventilated and is in room air to get a baseline value. And that's where is the baseline value. And then we're going to look the trends, if it gets better or worse. But we have to be cognitive that a baseline value on a hyperventilated patient may not be the truth, or the opposite comes true too. So it's very important to have a good baseline value. Same thing in the ICU. And you can set a baseline on the screen and follow that trend. I think that's the key concept I want to emphasize with that question.
It works. Grace, you want to say something?
Sorry, I think we have one last question for Joan, or no? Do you have SASHA on the pool? No?
No more.
Okay, so thank you, everybody. Hope to see you on Friday with Dr. Anderson, and next week. Please invite all of your team. We have a very nice session, a surgical session that's going to be interesting for everybody. Please be with us. Fill the feedback survey. And thank you very much to all of the speakers. I'm sure we all learned a lot. It was a very, very interesting session. Bye-bye, guys.
Yes.
Thank you very much.
Thank you very much. It was a pleasure.
Thank you very much.
Bye-bye. Bye, Edgardo. Thank you. We appreciate.
Gracias a vos. Gracias.
Ciao.
Bye.
Chao.
¿Quieres ver las preguntas ahora con